Okay, we're going to get started again. We are now privileged to have our crack CD team up here. So it will be Miranda and Mark who will give us a demonstration of what it actually looks like to do this in real life. And I will turn it over to them.
Okay, so I don't actually have my form in front of me, so it's going to be all in my brain, which
it'll be good now. It will be good.
Yeah.
So tell us what you're going to do.
So it'll be just the format of the phone call. So I don't really, the form is long and detailed, and I just kind of try and open it up so the patient fills it out for you, maybe not in the exact order that you have written down, but so that you're not doing a lot of like, and this, and this, and this, and this. And so it's more of a conversation than the interview, and they don't feel like they're being interrogated quite as much as it really is.
I think both of us had the experience. In fact, I know this because we've talked about this when we do these types. If you can get people talking, they will tell you everything or most everything you need to know. And at this point, I think with this, people are really open and talking. This isn't like some of our normal.
Yeah, we do STD work all the time,
where
so
people aren't going to want to.
People are usually
sure. Yeah, this is going to be hard because my back's going to be to you, but yeah, we mostly do STD work. And so we were saying a lot of people don't want to tell you those things, but this one, our experience so far, and Miranda has done far more of these than I have, but people are open to talking to you.
People want to help. They want to help stop the spread, so they're pretty.
So you have that on your side.
Yeah. Yeah. Okay, so we'll just
go for it.
Go. All right.
So you're calling a case right now.
Yes, this is on the phone. Yes, I am myself.
Yeah.
And Mark.
It will be Mark.
Some version.
Some version. We'll see where it goes.
Okay. Hi, my name is Miranda. I'm a public health nurse with Sonoma County. I'm calling for Mark.
Yeah, this is Mark.
Hi, Mark. This is a follow-up call from your visit to Sutter recently. Have they contacted you?
Actually, no, they haven't. I've been waiting.
Oh, okay. So just first to make sure that I have the right person, can you give me your date of birth?
Sure, it's 1/1/1980.
All right. Great. So I have the right person. So it sounds like your doctor hasn't talked to you, and that's not the way we like it to be done, but this is in follow-up to your test for coronavirus.
Yeah. Okay.
And that came back positive.
Yeah, I'm not surprised. I mean, that's why I went in. So.
Oh, okay. And so what did bring you in?
Yeah. So I was not feeling well, and then I started having like a little bit of a fever and then a cough, and so I just thought I better figure this out. And so I just called my doctor, and then they said come in because it sounded like it made sense for me to come in.
Okay, perfect. And so you said fever and cough. How long had that been happening?
So I kind of just felt really warm. So that was probably like maybe a week ago or so.
Okay. So I'm looking at a calendar.
Okay.
And a week from. So
it's like maybe Saturday.
So okay, a week from. So maybe Saturday the 21st.
Yeah, that sounds about right? Yeah, that sounds about right. Yeah.
Okay.
So I kind of was feeling like warm then, and then I didn't take my temperature till like the next day, and I was like it was like it because it was really, I felt really warm and kind of sweaty, so it was probably like 101, and I had this itchy throat for a while, or for like a day or before, and then like a little bit of cough, but and I was coughing a little bit too, so there was that kind of thing. So yeah.
Any other symptoms going on at that time or after?
I mean, yeah, I guess now I think about it, I kind of just had all the symptoms. So
what did that include?
So yeah, like maybe like some chills there was, and some body aches too.
Okay.
That's, I think.
And so I just have a list of different symptoms that might have happened, and you just let me know if any of those happened.
Okay.
How about diarrhea?
No.
How about you said muscle aches, you said cough. How about abdominal pain?
No abdominal pain.
Nausea or vomiting?
Well, my stomach just kind of felt a little nauseous, but I didn't vomit.
Okay, how about any shortness of breath?
Yeah, with the coffee. Yeah.
Okay. Anything else? Some people are reporting like loss of sense of smell or taste.
No, I don't think so.
Anything going on with your vision?
No, for me, no.
Okay, great. Okay, and so that started on the 21st. And so part of my call is to make sure that we kind of maybe have a little bit of an idea of where your exposure might have happened, but also, and that goes back to 14 days from your start of your symptoms.
Okay.
And then we go back 3 days from your start of your symptoms to see where you might have exposed other people that we might want to follow up with.
Okay.
Okay, so 2 weeks back from the 21st takes us to the 7th. So from the 21st to the 7th, did you travel outside of Sonoma County?
Yeah, outside of Sonoma, I was in San Francisco one day. We went kind of early on. We had a friend's party we were going to, so we used to live there. So we were hanging out in our old neighborhood at a couple of coffee shops. I went to a coffee shop, some other shops, walked around, that kind of stuff. And then we eventually went to our friend's birthday party. So that was like probably about like 20 people. And actually, now that I think about it, because this is part of when I was coffee and and like the symptoms is because I was talking to my friend and he said that one of the people that was at the party actually, they think that she tested positive. So,
oh, okay. Do you know her name?
No, but I can totally get that. I mean, I met her, but I don't remember her last name. It was like Cindy Lou something, but
okay.
I don't know. But I can get that from my friend because it's
Yeah,
his
that
party.
might be helpful. Okay. So, and what date was that party?
That was you said it was 7th. Is that the Saturday or
that was the 14 days, the 7th.
Yeah, so it was
Saturday.
it was that Saturday.
I think it was that Saturday.
Yeah, I'm pretty sure it was. Let me look. Yeah, it was.
Okay, perfect. Okay, and so we'll keep track of that party. And do you know of anybody else feeling ill at that party at this time?
No,
Okay.
no.
All
My
right.
friend's party, he's feeling fine.
Okay, you've checked in with him.
Yeah.
Okay. And so how about still on those 14 days, did you go to any medical appointments, maybe care appointments for your hair or teeth or anything like that?
Yeah, so on the 12th, I went to the dentist actually and had a crown replaced.
Okay. So anybody else when you were in the office, did you have close contact with?
Well, there was the dentist and the hygienist, but no, I mean, we kind of heard about all this stuff happening. So, I mean, people I think were like hand sanitizing. I was sitting next to some people at the, probably like 1 or 2 seats away in the waiting room, but not for very long.
Okay.
So, yeah.
And so I'll get the name of your dentist and I'll probably maybe making contact with them, anonymously letting them know. Well, maybe just checking in with them because they're not quite in the exposure from you window.
Okay.
But maybe.
Okay. Gotcha. Yeah, and then actually some friends came into town too, actually that Friday night on the 13th. Okay. And they stayed until Monday the 16th because it was right before this whole like talk of shelter in place and we weren't sure what was going to happen. They came anyway. They came in from New York.
Okay, so let me take down their names.
Sure. Blah 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 and blah blah blah.
And how about, do you have phone numbers that I could contact?
Yeah, totally.
Them with?
So here's their phone numbers.
Okay.
And we went like wine tasting that weekend, but again, this was kind of everybody was trying to social distance, and there was hand sanitizer everywhere. But they stayed at our house. So. Okay.
And were either of them feeling ill that you remember?
No. And I've checked in so far, and they're feeling fine.
Okay. Okay. So how about anything else? Any public transit? Any bigger gatherings, church, or anything like that?
No, because right after that is when the shelter-in-place order went in. So other than going to the grocery store, nothing.
Okay.
And I during those days, like probably like Monday and Tuesday, like the 16th and 17th, I was in my office and grabbed my stuff for work, and I'm working from home since then.
Okay. And what do you do for work?
I work in tourism.
Okay. So if you got sick on the 21st, going back 3 days, that brings us to the 18th. So who might have you been around in those 3 days?
That's so that's a good question. So I was at the grocery store, I went to Trader Joe's, then I went to Safeway. You know what, I did have to talk and come in contact with a couple of my coworkers. So we had to actually go into the office. I forgot about that part. So that's
okay.
So we had to run in there.
And what kind of contact did you have with them?
We just had to exchange some things like laptops and stuff and get all that settled because we're trying to just get prepared for this whole working from at home for an unknown period of time.
Okay.
So we're just kind of doing that type of stuff.
Okay, so I think I'll take their names and numbers.
Great.
And maybe check in with them as well.
Yeah, I can email that to you.
Okay.
Right. Yeah.
Perfect. Let me just get your email while we're talking about it.
Blah, 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 Gmail.
Perfect. Okay, and I'll probably use that email to send you some isolation guidelines as well as when your isolation period might end.
Mm-hmm.
It's always changing, so I'm going to include a link just so that you'll have the most up-to-date right there as well. Okay, so from the 21st to your test date, did you go anywhere while you were sick?
No, just been at home with my husband.
Okay. So your husband's at home? Anybody else at home?
No.
Okay. And how old is your husband?
He's like 40 something.
Okay. Is he feeling, how's he feeling?
He's feeling good. Yeah, he's felt fine. So, not sure what's happening there, but it's great. So we're pleased with that.
Are you guys able to use separate bedrooms and bathrooms?
Yeah, actually we've been distancing each other just because we've been reading a lot of stuff online. So we've just been kind of, I've been using the bathroom. We're lucky enough to have a second bathroom.
Perfect. Yeah. Wonderful. That'll help. Okay. For you and your general health, do you have any chronic conditions?
No. Like, do you mean like
anything that you maybe take medications for on a daily basis?
No.
Okay. All right. And have you ever smoked? Are you a current smoker or a former smoker, vapor?
Nope.
Okay. Wonderful. Let me just look at my form real quick. See if I've gone through everything. I think that's everything, but I might have to call you back if I miss something.
Yeah, totally. Just give me a call.
Okay. And so right now you're going to just, let's see, we're going to have you isolate yourself. It'd be best if you can keep in your room and your own bathroom as much as possible, keep out of the common areas from your husband, but be wiping down those surfaces regularly. He himself is going to have to also quarantine. I can talk to him if he needs further guidance on that, but I can send that for him along in that email. Sure. If that sounds okay. If he wants to talk, he can give me a call back at the same number.
Yeah, he'll probably have some questions. So.
Okay. So I think that's it. Do you have any questions for me right now?
No, I mean, it's all kind of overwhelming with all this information happening, but I think maybe once you send me this stuff, I can look at that and, figure it out.
All right. Well, thanks so much for your time, Mark.
Thanks.
And we'll be in touch. Okay.
All right, perfect. Thank you.
Bye.
Yay.
Yeah.
That was awesome.
I was mentally going through the list too. I'm like,
okay.
Thank you.
So are we
good? Excellent. Thank you very much for doing that. Can you guys just talk a little bit about what's different about contacting a contact? Like when you're calling a contact, how does that go?
Sure.
And you don't have to do a role play, but just explain it to everyone.
Yeah. So
you might need to repeat it into that microphone. I don't know if people are
you can hear us?
Yeah. I was hearing it.
Okay.
Great. Okay. Yeah. So it'd just be like same kind of introduction, and then I'm calling to let you know that you have been exposed to. I usually use coronavirus. I think it's more at everybody's level. And say I talk about who they might be around in normal contact. How are they feeling? If they have any kind of chronic conditions themselves, like I did talk to a pregnant woman that was exposed, just how that might change what they have planned for the next 14 days and how to work through that. Like I did forget to work through groceries with Mark.
I do have a question. If it's a family contact, then do you feel comfortable speaking about, if it's, say for example, the father and the exposure is in their mother, so the grandmother, and there's a whole family, like kids and everybody, do you feel comfortable speaking to them together or identifying who the person is because they're all in the same house?
Yeah, you know, I think that it's not like they aren't aware, generally speaking. I might talk
I'm going
to
repeat the question.
Yeah, okay. Yeah, so if there's a close contact that's actually in the family that you need to speak with, I mean, they're probably aware, but you can always check back with the case, the person that's actually positive, to say, is it okay if we just openly discuss the situation, which it does just make it so much easier.
I actually, thank you, Doc. That's really a good question, because I was interviewing somebody the other day and it was a couple. So I just wanted like the experience. So they both had coronavirus or COVID. And so they got on they just opened up the speakerphone and the kids were, and they were just open conversation. Luckily I had somebody shadowing me, Maggie, and she was able to like grab the sheet and write, all of a sudden I'm interviewing two people. Like these things are going to happen. And so, and then the daughter walks in who's 19 and is coughing, but she has allergies with the cat. And I'm just like, so it's like, okay, you're in control, slow down the conversation. And I said, okay, I asked the daughter a few questions because she was there. But I said, you know what, I'm going to talk to my colleagues about this, and we're going to get back to you about the daughter. And then refocus on the interview with them and just bring them back to their stuff. And then they were fine with that. They're like, great, they're going to go and talk to somebody else, figure it out. So
you have to be flexible to the situation. I also wanted to ask, so how is it different doing this over the phone? Because often with TV or other diseases, you might actually visit the household, with protective gear and talk to the case or the contact. Is it different?
So yeah, it is different doing it over the phone in that you have to kind of establish who you are and make them trust you, like Darcy was saying, and that's why I always include this as a follow-up to whatever you were going to, because if you have that kind of insider information, it might help to be like, okay, they clearly know that I was at my doctor, whatever day it was, because you're asking them for their date of birth and to confirm who they are, and they might not want to do it if then they don't trust you.
Yeah.
Especially older people, I think it's much more
older people that might be victim to scams
because they're used to scams.
Yeah, I think to some effect, sometimes, especially with this, things are moving so quickly. And this happens in our other area too. Sometimes people they don't necessarily hear that we're not with their clinic.
Yeah.
They just think, oh, they hear Sutter, I'm calling to follow up, and they think, oh, with Sutter. But we make it clear we're calling from Sonoma County Public Health. But we also talk about being colleagues with these places too. So that softens that.
Sorry, what happens when you call and there's no answer, but you get an answer, you get a voicemail?
Yeah.
Good question.
So when we leave voicemails, I generally say, hi, this is Miranda with Public Health, looking for Mark. Give me a call back. It's about a confidential health matter. And right now I usually say, I believe one that you're already aware of, because they might be freaked out if they were also, waiting on something else, or some people are more.
Okay. Yeah. And can you speak some to when you have a challenging situation where the person hangs up on you, or they say, who are you? I don't want to talk to you until my doctor says it's okay, or something like that.
Yeah, I mean, I definitely have that happen, especially in my regular line of work. And so sometimes I do just reconnect with that doctor to just let them know, just tell them public health is calling. This is normal, and please cooperate because it helps.
Yeah. If you have a contact that can call that from the clinic, like you said. I have to be honest, this is why we're good at our work jobs, is when I put that plug in. We call back. And sometimes I leave a voicemail like, we got disconnected, not sure what happened, but this is very important. So I'd really like to speak to you. And
Which might be more
Yeah.
reasonable in
Yeah.
given our
yeah,
times.
Yeah. And I want to just say, thank you so much. You guys did a fantastic job. And it's because you're so well trained and you know exactly what you're doing. I would advise anybody who's starting to use the form so you don't have to call back again and again.
Yeah.
And,
Yeah.
you know,
Definitely.
But you know, sometimes after we do our form and then we talk to Cinda and give her the overview, and then she'll be like, oh well, what about this? I'm like, ooh,
Yeah.
I must
Yeah.
have missed that. And
Yeah.
so usually I wait a while till I have like maybe a couple questions to ask them to call them back rather than just be like, and how about this?
Yeah, it's our experience to always finish with something like that because you are likely, even if you don't ever have to call them back, it's just nice to have said, I may need to call you back. And
Or
then,
you might want to call me
Yeah.
if you remember something.
great, that's excellent.
Yeah.
And so you give your number where they can
Mhm.
reach you
Yep.
and, okay.
Yep.
All right.
And I think there are a couple questions I've seen scroll
Okay.
by on the screen before we let you go. One
That's cool.
was just in terms of contacting provider offices. If somebody has been to the dentist, are you allowed to disclose who that person is, or how do you work with a dentist on that? Because it is a little tricky.
It is. Yeah.
We're working out because actually it was my, go ahead, Mary, what do you? Yeah. Yeah.
Mary, do you want to get up? to
Yeah,
the
I think I know what,
microphone so that
Mary, I can
yeah.
say it.
Or-
We know the answer because this is actually in our real life, this is it. So
Yeah.
what we usually is tell people is that we're contacting you, you know, to the point, like what I usually say to other contacts in my other world when I do STD work, it's like somebody wants to make sure you're staying healthy. We want to make sure you're staying healthy. Somebody you've come in contact has tested positive for this. I don't say this to them, but it really doesn't matter the point of who it is. But some people will press back
Well, I
on
mean,
you.
if they're a
Yeah.
provider's office, maybe they're seeing certain
Right.
people or a PA or a
Right.
medical
And
assistant. and-
Someone might say, oh, well, I bet it was this person because I saw them sneezing or coughing. And you say, I can't confirm anything.
Yeah.
But they might know exactly who it is. And
I get. Yeah, that's
Yeah.
yeah. We can ask the
Yeah.
patient. We can use their name too. Yeah, I mean, I think that we're learning quickly on these two. I get to see your point, right? Because what if only certain people have been in the room with the
Right.
individual? You don't have to test the
Or on that
whole
day, somebody's
office.
on
Yeah.
their half day.
Yeah.
The other thing that people have asked is, what about people for whom English is a second language or they don't speak English?
so we
Do
have,
you have translators, or how do you do
well,
that?
we are benefited by a lot of Spanish speakers.
Yes.
And so we try not to do the translation thing because things give us a translation.
Yeah, good point.
They do.
And so we try and just have someone who speaks the language talk to them directly.
Mhm.
And if that's not possible,
Yeah.
do you have translators available?
We have translator line if we need it, but I don't think we've needed it yet. But yes,
Okay.
Yeah.
that's just standard, I think. For
Yeah.
us.
All right. Thank
Good
you
question.
so
though.
much.
Good
Yeah.
question.
Yeah, I'm sure there'll be a lot more questions, and we can discuss this a lot more during the Q&A.
Okay.
We have
Let's
one
just-
more question in the room.
In the world of robocalls,
Yes.
I'm afraid that many people will not pick up the phone if they do not
Right,
recognize
right.
the number. And so if we call from this place, which number will be exposed?
Yeah. Can you repeat the question?
Because we come from different.
Right. So the question is about in the day and age of robocalls, especially robocalls that match phone numbers that So it's what will show up, or I don't know if that is exactly the question, but yeah, just will people pick up that's when I heard that question. It's like, are people going to pick up or recognize phone numbers?
I think we're calling from different lines.
Yeah.
So, I mean, we never mask our line as far as I know. So they might call back directly to the line that you were calling from. But that's why you just leave a, general voicemail, especially because sometimes the phone number is wrong.
Yeah.
But
Yeah.
that's why I don't even include their last name most of the time.
Yeah.
Does that answer your question?
I'm not sure if it answers it. Yeah. It's a bigger, I think, question, right? Will people be answering the
Yeah,
same
But
age?
so far, you've had a pretty good experience.
Oh, yeah.
We have, and people for the most part are, like I said, very willing to try and help.
Yeah.
Stuff.
Yeah, and I think that might speak to, maybe there isn't as much worry about being identified or stigma
Yeah.
Mhm.
I think
at
there's
this
not.
time associated with being COVID positive,
Yeah.
possibly.
Yeah.
I don't know. I think it may still be an issue.
Yeah, the people I spoke
But,
to were
you
just like all about talking.
Yeah. Yeah, they want to know.
They want to know,
Mhm.
and they want to keep. They even mentioned like we want to keep the county healthy. It was just really
Great.
sweet. Yeah.
Fantastic.
But I think it is important to be aware of, especially with certain ethnicities where there may be some
Mhm.
sensitivities around coronavirus, that we definitely need to be sensitive to that.
Yeah, absolutely.
Great.
Thank you so much,
Yeah.
Dr. Miranda. Okay, and I know we have a lot more questions to answer in that regard, and we will get to that during the Q&A. I just want to wrap this up quickly, the rest of my presentation, and then we will go back to Cinda to go over the form that you need to fill out. So I see some of the questions were, what exact form are we talking about, etc. Okay, so this is just a quick and dirty of what we're thinking of, and this is draft. But this is a basic information flow for how we're thinking this is going to work in real life. So when we get a positive case, where does that notification come from? It comes from the laboratories. It could be the public health laboratory. It could be a private laboratory. It comes from individual providers. It could come from the CalReady system. So they identify a positive case, a positive test result, and they report that case. That information goes to the communicable disease team, as I understand it. And you guys correct me if I'm wrong. So the core disease control team and the epi team, I lumped them together since they're sitting together. So they will receive the report of that case. It will be assigned to a communicable disease nurse, and the information, the preliminary information, gets entered into the database. And then the nurse who is assigned that case receives the information for follow-up, does the phone calls to the case and identifies the contacts, and works with the epidemiologist to make sure that information gets put into the database. And then our surge help, and who exactly that is will depend on what it is we need to have done. So it's a bit fluid right now. It may be public health nurses, obviously, to help do some of the interviewing and the contact investigation work or the contact tracing. And then there are follow-up phone calls to the contacts just to check in with them. That may be lower levels of staff who are just trained to man the phones and be able to touch bases with people on a regular basis and refer that up to someone else if they're starting to have symptoms or if they have questions that can't be answered. Okay? And then that information will go back to the CD nurse who's in charge of that investigation. So this is more the relationship between people. This is not, as I said in this slide, it is not an organizational chart. So it's not the command structure. It's just really, how does communication happen? So Dr. Mace, as the health officer, is the person who can answer questions, technical questions, medical questions, make decisions that need to be made about quarantine and isolation and release from that, etc. She's going to be working directly with the communicable disease core team, which is with the nurses in the CD group and their supervisors, and the epidemiology team to get the information and look at the data and analyze that data and see where we are and help prioritize investigations. And then the nursing directors will be the linkage between the communicable disease core team and the other staff who may need some support, training, mentoring, guidance on a daily basis as to, questions that they have, what to do about certain things, how to move forward. So there would be a contact tracing team, which is actually taking those contacts and following up with them, and a phones team then to maintain the continuity of contact with that contact. The contact with the contact with the contact. Gets a little confusing, doesn't it? So we'll be calling those contacts on a regular basis just to check in during their quarantine period. And then a data entry team to help make sure that all of this information gets put in real time so we can really know where we are with things and stuff doesn't start falling through the cracks. That's the basic structure we're thinking of. And this is really not only for us in Sonoma County, but our colleagues in Lake and Mendocino who are thinking about this and wondering how to, what sort of staff they're going to need. And again, when we're talking about recruiting, and I saw this go by in the questions, someone asked, well, who are you thinking about recruiting? And again, it depends on the tasks that we need help with. It will be PHNs, it will be other staff, obviously disease investigators, and others as needed to help us fill these roles. So the other piece of skills is around using data to help guide your strategy and prioritize your investigations. So obviously we're going to use these data to follow up our cases and our contacts and manage them. And then we're going to spend some time, as Cinda has already done, analyzing what we have, looking for clusters of cases that may need some further investigation. So if we see a lot of people who are starting to have symptoms or have positive results who belong to the same cluster, then we're going to start thinking about, okay, well, who else is in that cluster that we need to reach out to? Numbers of the contacts identified, how many are positive, how many are asymptomatic, et cetera. So just to keep tabs on what we're doing. And that is the end of my presentation. We're going to hold off on the Q&A until Cinda has time to go over the actual form that needs to be completed. And then we'll try to have as much time as possible for some Q&A. So back to Cinda.
While we're getting the slide deck up, I just want to talk a little bit about why we're collecting some of this information, and just to give you kind of a broad overview of what we're trying to do. And then if people have questions for why we're collecting all this information, you can also use these as talking points. One thing, this is really contributing to our understanding of how this disease is moving in our community. Sonoma County has very different demographics from some of the other counties. We have an older population. We don't have some of the risk factors that they do in China. We have different risk factors here. And so we really want to understand how it moves through our community, what the symptoms are in different groups, what the role of underlying conditions plays here locally. We want to look at age and how that relates to these things. And then in terms of like the person's history and where they've been, we want to know how potentially they were exposed. And then after their onset date and a little bit before, we want to be looking for who else was potentially exposed. Okay, so this is going to look long, but I'll tell you this case interview form is 3 pages long, with a lot of space to write. And so we'll just go over this piece by piece so you can understand what the questions are and why we're asking them. So this is the top. We're asking you to fill out your name and the date of the interview, and then your form will come with its CalReady case number, and this is how we can identify it in the database. And then the person's last name, their first name, and their date of birth, which again, you can fill that out before the interview so you can confirm with the person that it's them. Their phone number, and then their email address. And then also their residential address. And the reason that's important is that some of these cases come in just through lab reports. And so if they haven't been hospitalized, it can be tricky to get their address from, and we may not have time to gather all that information from medical providers. And so it'd be great to collect that right here. And then who their healthcare provider is, and then if they're linked to another case and we know that in advance, we'll go ahead and fill that information in there. So the first question on the form is, what do you do for work? And again, as you're doing the interview, I think this stuff will come up organically, but we're just going to go through it in the order it is on the form. So what do you do for work? And then describe the setting if that applies. And then who else is in your household? And then there's space to write their name, their date of birth, their relationship, their contact number, and then if they have symptoms. And then we've recommended that if people in the households have symptoms and are available to be interviewed, to go ahead and start a new interview form for them if it sounds pretty convincing and you have time. So then if the person says that they're a healthcare worker, are you a healthcare worker that provides direct patient care, yes or no? Or do you work or volunteer with any sensitive populations? For example, if you do volunteer work on the side with the homeless, if you make regular visits to congregate care settings or prisons or jails or daycares to write letters or to do art projects, which may not be happening now, but could have been happening before. And then if yes, what is this occupation setting name, their last day of work? And then did they work after the symptoms started? And then I just want to say one thing about the check boxes, and I'll say this again. It's really important that if the person says no, to check no and not to leave it blank. Because if it's blank, I'm not going to know if you asked the question or not. And so, no, it's really important to just go ahead and slash through the no if that's the answer to the question. So then if they do work in healthcare or do any work with sensitive populations, we've left space to describe that. It's really hard to get a checkbox answer to all of these particular situations. And so we just want a narrative description of whatever it is that person does. So maybe they work with disabled children 3 days a week at this location, and the last day they did that. So then is the clinical information. And this is the checklist of conditions that we know are risk factors for severe disease so pre-existing medical conditions, chronic lung disease, diabetes, cardiovascular disease, chronic renal disease, chronic liver disease, if they're immune compromised, if they have any neurological issues, diseases, if they're a woman currently pregnant, and then the questions about smoking. And then if they mention something as a pre-existing medical condition and you're not sure how to classify it, just go ahead and write it down. This happens to me all the time. Someone will say something or write something down. I'm not sure what it is. I have to look it up to see if it fits into that box. And so I think it's important on all of these is just to write it down if you're not sure, because we can always go back and look at it later or talk to Dr. Mace, does this qualify? And then the other thing we're going to add, Miranda made an excellent point, we're going to ask people what medications they're taking, because she asked that question and they had said no to all of these things, and I can't remember the specific example. But if someone said, oh, well, I don't have any medical conditions, but I'm on Ventolin and prednisone, then that, suggests that they could have asthma. And so knowing what medications they're on might give us other clues to what pre-existing medical conditions could exist. And then you can also circle back if you recognize the medications and say, oh, are you taking that for hypertension or, whatever applies. And then we'll take a minute to grab the next couple of slides. And then while we're waiting for that, just a note on smoking. It's really whether you smoke anything, marijuana or cigarettes. Okay, and then the next section is symptoms. So there is the date of symptom onset, which you can ask them, when did this begin, and write down the date. And then here are the list of symptoms known to be associated with this disease, and then a free-form box at the bottom for other, when you can write it in. And then again, if they mention these on different dates, there's space on the side to write in the date. So if they say that their onset was on March 14th, but then they're like, oh, I had a fever on the 12th. Like when you get to that, you can always write that in on the side, and then we can decide later what their official. Okay, and again, this is another situation where it's really important to, go ahead and say no or unknown. So if they're not sure, if they can't remember, to go ahead and make sure that you're clicking no. Great. Okay, so now we're going to the exposure history. So whatever their first symptom is, we're looking at the 14 days before. And here we wanted to give you plenty of space to write. And, we're trying to prompt with a lot of different options, but not be limiting. So in the 14 days before symptom onset, did the person travel outside the county? And the dates and the location and any notes. And then attend any appointments for medical care or personal care. And again, we're looking for these like personal interactions within 6 feet, even, acupuncture, anything where they may have interacted with someone in a close setting. And then again, we're trying to be as open as possible, attend any group gatherings, including work, sports events, parties, anything else, any other events in group settings, going to church, going to the gym, public transit, anything else that would have been close contact. And then if the person knows if they've had close contact with a lab confirmed case of COVID-19 while they were ill, yes. And then if they're comfortable sharing the name with you, that really helps us make these epi-links. And then if yes, if they can describe their interaction, oh, this is a coworker, we're in the same office all day, every day, or it's a household member, or in some cases, people are called from other counties or us, notifying them that they were exposed to a lab confirmed case. So they may not know the name, but they could know that they were notified by someone that they were exposed. And then laboratory testing, not everyone is going to know this, but in case they do, if they've been tested for influenza, and if they have, what was the result? And then if they've been tested for any other viral respiratory illness and what were the results? And that's just in case they know. Most people won't, but if they do, it's really great information for us to have. And then after that, there's just a section to write any notes and comments. We know not every situation will fit on this form, but there should be plenty of space to write any other information as needed. And that's it. So thank you so much.
And start answering some of those questions.
Do you want to start from the bottom? Then I can scroll up.
Yeah, that's probably easiest. Okay, and so I'm going to need Dr. Mace to answer some of these questions, and probably the CD team as well. So if you guys want to come up here, do it so it doesn't take too long. Any utility, okay. If contact is outside of our county, do we still do the interview? CD team.
Usually no. Maybe if they worked in our county and we really want that firsthand information, but normally we would pass that off to whatever county that is, give their whatever information you're able to gather and send it off to whatever county they live in.
Is there an interjurisdictional transfer form, or is it just a phone call?
You know, right now we just are doing phone calls, but then CalReady also has the ability to transfer that information, so it's also electronically entered in.
Okay, great.
Okay, so where was the space in the form to put in names of people that the case was at a party with?
There's a note section.
Yeah, just in the note section. There's no, other than household, there's no place for the close contacts.
Okay, so just put any other contacts you identify, especially by name, in the notes section. The difference between the flu test, rapid versus PCR, will you post the slide specifically, quarantine versus isolation? All of the slides will be available. This is being recorded, and as I understand it, all of the slides will also be available. Yeah. So we'll make sure that everybody who's on the call gets that link or knows where to find them. Okay, we got that one. Any utility in asking, sorry, can you go up again? I just want to.
Oh, interesting, I can't. Any utility in asking or knowing whether they received flu vaccine for this season?
I mean, these are confirmed cases at this point of COVID. So although I don't think there's any reason for us to get the information about whether they had the flu vaccine for the form, not for the purposes of our surveillance, I don't think.
Do you want to answer the question about PCR?
That's a good person to answer.
Yeah. Okay, so there was one lab question about the difference between a rapid flu test and the PCR.
There's a lot of different platforms for flu testing. So a rapid flu test is usually like a lateral flow device and it's antibody based, whereas a PCR test, it's looking for actually like parts of the flu virus. So that's the difference. I don't know if you wanted more specifics about some of the aspects, but you can reach out to me.
Do you want to answer this one?
Yeah. Okay. I think it looks like Mandy asked about also the form being electronically available. Right now it's in Word, so you'd push around all the questions and make it look funny if you did that. Maybe we're going to change it into a PDF fillable at some point, but I don't know because we're also changing things. And then Maya asked about I asked about 14 days for, and that tells you about the exposure, where they might have been exposed. And then I went to 3 days to ask about who they might have exposed. That's the difference there. So I was asking about both periods of time.
Now where are we?
I don't know. I'm sure they will,
quickly.
Okay, let's just, we got that. Please review what it is you want volunteers to do. I don't know how relevant this information is for me. And again, we're still sorting through exactly what volunteers will be doing and which skill sets are going to be doing what. We're going to need people to perform contact investigation or contact tracing in terms of being in touch with those contacts and doing contact interviews and following up with contacts as part of a phone team. So there are a couple of different roles, and as things progress, as we get more and more cases to investigate, things may change, but that's the current thinking at this point. And I don't know if Mary wants to say anything more about that, or anyone else. Dr. Mace?
Yeah, I mean, I just want to say we're really thankful for all the people who want to volunteer. And as Darcy just mentioned, the more cases we get, the more likely we're going to need more assistance. So we just have to determine what your skill set is and how you could be useful in helping us. If it's simply calling contacts to see how they're feeling, that sort of thing, it's a script. So really anyone might be able to do that if they're trained to read the script and just take notes and report back. So we'll let you know. And Mary, do you want to say something? Good.
Hi. People who are on the call, we, like Darcy was saying, we haven't completely set up who's going to be doing what role, that type of thing. But if you are interested, can I have them reach out, just send me an email?
Yes, and in fact, I've received emails already. I know, that's a great idea. I think I'm gonna have everybody reach out to Mary to coordinate that, because
so my email is mary.miller, and there are 2 Mary Millers at the county, so just mary.miller at sonoma-county.org. And just let me know your contact information, your email, well, of course you'll be sending your email, but your contact information, best phone number, and where you work currently and your title there or your job duties there, so I have a sense of what your, are you a practitioner, are you office assistant or a resident, that type of thing. And
important to have a license.
if you have a license, just give me your credentials and then we can move from there.
Yeah, and several of you have already reached out either to Linda or to me, and I'll forward those emails, or Linda can, to Mary, but you might as well reach out one more time to make sure that we make that connection. And we really appreciate all the people stepping forward to volunteer. We'll find a role for you, don't worry.
Yeah, and I just want to say, just in terms of how this information is relevant for you, if you're not going to be doing a lot of these things, I am always an advocate of everyone understanding what the big picture is and how you fit into it. So even though you might not be doing some of these things, I think it's really important for you and helpful for you to understand how the whole system is going to work. So I think we have some more. Can we scroll down
on the flu question?
Oh, okay.
Yeah. So somebody clarified on the chat. Thank you. The rapid flu test is a test you wait for. It takes like 15 minutes, and you know with pretty good certainty whether you have influenza or not. Whereas the lab test takes 24 hours.
Our turnaround time is 24 hours.
24 hours.
So the next question is, can you clarify if people experiencing homelessness are a high-risk group? And the answer is yes.
Absolutely.
Yes. They are considered a high-risk group. We're working on trying to accommodate all people who are, well, okay. There's some sets of homeless people who we see as particularly vulnerable, and maybe you want to define who those are.
Right. So the homeless population obviously is extremely vulnerable because they don't have a place to live. They're in shelters, crowded conditions, more likely to be exposed to coronavirus, but also all kinds of other pathogens. Often there's substance abuse issues, but then there are also underlying medical issues as well, because they probably don't have the best access to medical care. So there may be a lot of different comorbid conditions. Many of them are actually older as well. So, I don't know, is there any other specific risks you can think of? So yeah, they're extremely high risk. And I really, we have a plan, a homeless task force and a plan for addressing this. And we'll be doing specific things to make sure this group is as safe as can be and tested if need be.
And then maybe Rachel, you can address the question about, are we going to get the 45-minute test kits for our county?
Hi, we will not get that test kit in our laboratory, but that doesn't mean that some other program in the county might not be using that test kit.
Yeah, but one thing I want to just add is that Cepheid, which is a group that does the rapid testing for many other communicable diseases, TB, for example, hepatitis, HIV, chlamydia, they are coming up with a rapid test for coronavirus. Our lab has a gene expert machine, thank goodness. And so hopefully when the test becomes available, it's a cartridge-based test, turnaround time 2 hours or 4?
I'm not sure.
I think it's 2 to 4 hours, yeah. And so this will be fantastic if we can get that up and running for our lab.
You want to answer that one? Sure.
For how is contact data shared between counties? So we do have the online system, which is CalReady, which all the reportable conditions are reported into so that the state can gather that information. So that's when we can make a form for the person and then send it electronically. But we usually follow that up with a phone call because we have all the contacts for the other counties and their communicable disease units. So that might not be something that a volunteer would be doing necessarily. It might come back to our core group of disease control nurses to send off to do that.
Right. Yeah. Okay. There's another question here about what can we do to create awareness besides news and social media? I think
that's a PIO question.
Yeah, we have
PIO?
A communications team. They're not here right now to be able to address that. I think certainly just as a private citizen, you can certainly be in contact from a distance with your neighbors to make sure that they understand things and talk to the people you know, your friends. Okay, we've got a lot of questions or a lot of answers for Mary about her email address, and then maybe including languages that you can speak on that communication would be helpful, and I agree. So I think everybody has typed in Mary's email address, so everybody in the world is going to know it now. You're going to be getting plenty of email, Mary. There was a question earlier that might be missed. For a question about smoking, are you also considering cigars, cigarillos? Yeah.
Yeah,
Cigars,
any
cigarettes,
tobacco.
cigarillos, yes, yes.
I think we should
That
include
is
chewing tobacco
smoking,
too.
yes, yeah.
Seriously.
For those who are retired and want to continue to shelter in place, can we do all this phone work from our homes?
Oh.
I think that's possible, yes. Absolutely.
We'll have to discuss and.
But we'd have to, we just have to figure out how to make sure that everything's working smoothly. These are details that are all good questions to ask so that we can think about them as we try to plan this. Yeah, let's just go all the way up to the place where people are complaining about not being able to get on, and then we'll go down from there. Okay.
Yeah.
So I know somebody asked about who is essential, and I think the essential people really are the people who are going to be doing this work and their supervisors, and then everyone else. But feel free to, if people are interested, people who are interested, there will be an opportunity to get this recording and see it at a later date. So if you have colleagues you'd like to have see it, encourage them to see the recording. Julianne has a comment or question.
I just wondered if Rachel could speak to the turnaround time of the public health lab and how the increased testing may affect that.
Right. So Julianne is asking about how an increased volume at the public health lab might affect the turnaround time for test results.
Hi. One of the reasons that we're still prioritizing testing requests through disease control is to kind of help control the test volume that's being tested at the public health lab. So like I said earlier, our daily maximum capacity is about 120 specimens, and we are working on, a couple different ways to kind of expand that. But we're never going to approach the test volume of like Quest or Kaiser, who's really geared for high volume testing. They're doing like, hundreds or thousands. Quest is doing thousands a day. Yeah. So our turnaround time, right now it's 24 hours with that 120 tests. And so if we are getting more and more and more samples into the lab, then we would have to extend our turnaround time to like 48 hours and then 72 hours. And we don't want to do that.
Rachel, there are a couple of other questions for you while you're there. One is just a reminder with refrigeration requirements, be careful of your pickup times so they don't stay out overnight and have to call the patient again. And then can you post on the county public health website the lab specimen requirements? So can we just say that?
I think there's a couple different websites. The laboratory does actually have a specific website for the lab. So if you Google Sonoma County Regional Public Health Laboratory, we have links from our landing page about COVID, and our specimen requirements are there. And because, and you can go from socoemergency.org, you can link from there to the lab website. And I'll just say, because like the sample requirements, CDC kept approving more and more things, and this just happened Friday, so I need to put in a request to ISD to update our website. And if you want the really latest stuff, get on my email list. So you can email me at rachel.reese@sonoma-county.org.
Oh, and one other thing, did we mention that they can freeze specimens and they'll last longer?
Specimens can be frozen, however, they need to be frozen at like -70, and you want to avoid freeze-thaw cycles. So yeah, the best thing is to keep them refrigerated and transport them rapidly to your testing laboratory.
Within 72 hours, they have to be run, correct?
Right. Refrigerated samples are good for 72 hours. So if you can't get the test run within 72 hours, then you want to think about freezing, or you'll have to recollect.
Yeah, I just wanted to say one thing about the specimen collection, and Rachel, you can help me out here. Mm-hmm. So the swabs are a big issue, right? That's been one of our limiting factors for testing. There are several alternatives. So there's the nasopharyngeal aspirate, and you've put out information exactly how it's collected. It's a little bit more invasive, but it can be performed easily in the outpatient setting. It is a little, patients won't like it as much, but I still think if there's no other recourse, collect that specimen. The other thing that just came up, if your patient has a cough, you can collect a sputum, just like we do for any other pneumonia or TB or whatever. So that is an option if there's a productive cough. So we got to start thinking outside of the box to get our specimens in.
So looks like says, so are we assuming that people are only infectious when they start having symptoms? That's why we go back 3 days from when that infection
that's $1 million
starts.
question.
But I mean, we can't know, it's too new. So we go back 3 days before their onset to just do the best we can.
And it makes sense, because as Darcy also noted, not everybody's going to remember exactly when they became symptomatic.
Yeah.
Right. So going back 3 days makes sense, and I don't know. I mean,
and so Right. So for the onset, for the timeline, for the contacts, you have your onset, when the symptoms started. We're going back 14 days to gather all kinds of exposures. The 14 days really shows us where they were exposed at the very outset. And then when you get closer to the onset, that's who they might have exposed. And as far as the Spanish speaking for contact tracing, we still do have a pretty good amount of staff that are Spanish speaking.
Oh, and this is something that maybe you can speak to.
For South Korea was using credit card statements to help cases find their contact locations. Could we suggest they look through the text messages and our credit card statements to have a more thorough list of contacts? So sometimes, yeah, when people are having harder times, like Mark mentioned, we, in our normal STD work, we do have them dig deeper into their life to try and figure it out, you know, spark some memories or whatever. So that's something we could definitely use in people who are having a tougher time.
Yeah, and if I can just say, you know, we're really focusing on close contacts in this intensive contact investigation. There's a lot of work to be done. So I think expanding to large work sites and churches, or, I mean, now there's shelter in place, we really shouldn't have that much of that, but it's not our intent to go to large groups right now. We just need to do really focused, intensive contact investigation, vulnerable populations and close contacts. That's what we're focusing on.
Sundari, do you want to talk about this?
Okay, isolation only applies to a person with positive test, question mark. So everyone with mild symptoms, okay. We're isolating patients who are
Can you just
positive.
read the whole question so everybody knows where we are?
Okay.
Is this one?
Okay,
So
should everyone with mild symptoms get a test? And the answer is no, because at this time, as we've already stated numerous times, we're prioritizing the most high-risk people who are most likely to have COVID as a result of contact and who are most likely to be having negative outcomes with COVID if infected for testing. So at this time, we don't have the capacity to just test in large groups of people. If you have mild symptoms, you should see your provider and get evaluated. And that person is going to help determine whether you're going to be tested or not. Of course, it could still be the common cold. It could be influenza, even though that is now beginning to decrease rapidly. It could be other respiratory viruses. Those things are also still common out there. So I don't know. I mean, Darcy, I don't know if you want to add to. I think that's appropriate. You know.
So the other question is: Are the two negatives that we're requiring for healthcare workers, et cetera, within the 10 to 14 days or after the 10 days? It would be after the 10. I mean, so for people who are cases.
Yeah, let me make this really clear. Well, we're not doing routinely sputum testing at the end any longer because we've found that people can stay positive on sputum for a while. Now, the CDC recommendation is 7 days of when you're symptomatic, 7 days isolation for sure, and then 3 days of being afebrile specifically and getting better for, and that could mean that you're only in isolation for 7 days total, because what if you never had a fever, right? There's about 30% of people, according to Cinda's statistics, even on our own cases, that are afebrile, okay? So those people would be 7 days. And then someone could be up to 14 days. Let's say that they actually continue to have fevers all throughout. But we're not retesting except in situations where we have healthcare workers or staff that are going back to work with high-risk populations. That's the group that we're going to require 2 negative tests taken 24 hours apart. That could be even further out.
Could it be before?
It could be, well, only after, between 7 and 14 days.
Okay.
It could be between, if they're asymptomatic. Okay. So I think it gets complicated. Yeah. And we're just starting to apply these things. So when these cases come up, we need discussion about it. And it's going to be on a case-by-case basis what we do. But we're not routinely going to waste our tests on people who are positive to figure out that they've become negative.
Okay, so somebody asked, would you please instruct why double gloving is unwise?
I think somebody else should answer that. Who's in the front line? There we go. Dr. Lassie has a perfect explanation. We don't have enough gloves. And there's no indication that double gloving would help, right? I mean, this isn't like we're suturing and we want to make sure we don't prick ourselves. We can prick our outer glove. It's not like that.
Okay, so another question maybe for the CD team. If we can't tell them who the person is they were exposed to, how will they be able to count 14 days from last contact?
We do inform them of their last date of exposure. So sometimes that is why they can know, oh, well, I know exactly who it was then, which we can't keep that from them. Like, just, right. We don't name names unless we've been told that we are allowed to by that case.
Okay, another question, Dr. Mace. How do you prioritize testing for exposed and symptomatic healthcare workers? Do you recommend testing every healthcare worker who had been exposed to a case, even with just slight symptoms like sore throat?
That's what we're moving to, because we want to be really on top of picking up healthcare workers, because they're in a position where they can expose a lot of vulnerable people. But we're letting the healthcare facilities determine who would be tested in their environment. So, you know, I think that group should determine at that point. I don't know, Dr. Lassie, you are representing healthcare facility. So what do you think?
That's a super complicated issue, and it seems like a unified standard across the county would probably be better than everybody making individual decisions. But
yeah, so let me just say, from the public health department standpoint, if a healthcare worker is asymptomatic, they're still going to be doing what other folks who are exposed, who are asymptomatic would be. They can go back to work. There's guidelines for that. And we've posted all those guidelines. If a healthcare worker is even minimally symptomatic, I believe they should be tested.
Okay.
They test twice though before they come back to work?
No, it's just one test. Even though you have a point that maybe the ability to detect real infection, there's always a problem with that. In other words, you have false negatives, right? And some of the early reports suggest that the false negatives are higher than we want. I mean, they're 18 to 37% false negative. Having said that, if we go to doing both the NP and the OP swab locations, we think we have a higher sensitivity. So I guess a thought is that if someone's negative and they're still really symptomatic, this is something we were just discussing, Rachel and I. If someone's really symptomatic, really ill, you know, working in a situation where they're putting others at risk, of course they shouldn't be in that workspace, but we could consider testing again if we were really thinking they could be a case and it would make a difference. If they're hospitalized, super ill, no other diagnosis, not doing well, yes, we'll retest them, that kind of thing, you know.
And so first responders have a document from the Coastal Valley EMS saying they have to have 2 tests, so that's going to change when we see some updating.
2 tests. Yeah, I think we need to review that then and see. Okay, it's something that we'll talk about then. Okay. That might have been old.
The question is, do you need to speak to the affected person directly? Is it okay to speak to a caregiver or guardian or translator? So, I mean, there are times when we can't speak to the affected person directly, and we'll try and figure that out legally. But at all costs, we try and speak to the person directly because they know their goings on the best for the most part.
Okay, so what kind of availability do interviewers need to have?
Hi, this is Mary again. We want interviewers to be able to work an 8-hour day.